Good afternoon, everyone. Welcome to The Good, the Bad, and the Ugly of Going Big, NCSD's webinar highlighting the creation and expansion of the school-based screening program in Washington, D.C. My name is Sandra Sedna-Smith, and I'm the program manager at the National Coalition of STD Directors in charge of all of our adolescent health initiatives. Before we get started, I'd like to introduce NCSD's Executive Director, William Smith, who will say a few words about the organization and our current adolescent health efforts. Bill?
Thanks, Sandra. And can you hear me just to make sure I'm coming through?
I can hear you fine. I'm going
Great.
to check the chat and make sure people aren't indicating otherwise.
Do you want me to wait, or shall I go ahead?
You can go ahead.
Okay, great. Thank you, Sandra. First, let me say thanks to Sandra, who's really done an amazing job here at NCSD in providing leadership to our members and to our partners, and really focusing on the disparities related to STDs among adolescents. And we're really pleased to be presenting this webinar today as part of that ongoing work from our organization with a specific focus on young people. I also just have to pause to say I'm really proud and happy that this one today is on Washington, D.C. In addition to serving as the Executive Director of NCSD, I have the great privilege of serving on the board of a local AIDS service organization here in Washington called Metro Teen AIDS. It's actually the only DC-based organization with a specific focus on young people. And I can tell you, not just from my perch at NCSD, but from my perch on being on the board of Metro Teen AIDS for I think 6 or 7 years now, that the role of our partner, our member in DC, and the schools has absolutely changed the way young people are accessing services and getting educated around STD prevention. And I just wanted to say how proud I am that we get to take part in this today and to present this information to you. Just very briefly, the National Coalition of STD Directors is a membership organization. We represent the 65 directly funded areas from the CDC to do STD prevention. Those include every state and territory, and then a number of directly funded large cities and counties. In addition to providing services to those members, we have a specific focus around eliminating health disparities, which again is part of our focus today with the webinar on young people and STD screening in schools. We also focus on Native American populations and increasingly on other communities adversely affected by STDs. We also focus pretty specifically on policy and advocacy efforts at the national level, providing leadership and increasing CDC resources to do STD prevention work, and are continuing to really urge for some greater investments in STD prevention through that work. So I will stop there, and again, thank Sandra, my colleague Sandra, for the amazing work that she's doing, and turn it back over to you. And again, just thank everyone today for joining in on the call.
Thanks, Bill. I really appreciate that. And as Bill mentioned, this webinar, as you can see on the screen before you, it's supported by our funds from CDC Division of Adolescent and School Health. Without these funds, we could not produce the webinar that we have today, so we're grateful. But I also need to point out that all the content you'll hear today is solely the responsibility of NCSD and does not necessarily represent the official views of the Centers for Disease Control and Prevention. So now that that's out of the way, I'd like to go over a couple of, just a few slides about the technology. As I indicated earlier, and as you're well aware, the lines are muted. You are able to submit questions to us via the chat. I'm designated as the chairperson. You can also send questions to our presenter. She will do her best to answer the questions as we move along. But in the case that she may overlook one because, presenting at the same time and viewing the chat box can be challenging at times, as we all know, those of us who've done presentations, I will be making note of any questions in the chat, and we'll have a dedicated question and answer session for the latter part of this presentation, hopefully the last 20 minutes. And I'll review and read out the questions that we've received in case we've missed any along the way. In addition, this presentation is also being recorded. A link to the archive recording and the presentation slides will be sent to all of you and anyone who registered, even if they couldn't make it. A link will also be posted whenever our brand new spanking website will be up soon. And I have been posting on STD Prevention Online as well, the links to the archives. So today you will hear from Melissa Selvag. She is the Outreach and Capacity Building and Special Initiatives Coordinator with the Bureau of Sexually Transmitted Disease Control at the HIV/AIDS, Hepatitis, STD, Tuberculosis Administration within the District of Columbia Department of Health. She has worked for the DC Department of Health for 4 years. And in her capacity there, she is responsible for the development and implementation of programs and trainings to reduce the impact of STDs among adolescents and the general population in DC, a task accomplished through the provision of training and technical assistance to community partners, the development of new outreach tools, and assisting with the implementation of an expanded condom availability program. Previously, Melissa was the Deputy Director of the Family Ties Project, where she provided direct services for families infected and affected by HIV/AIDS in Washington, D.C., as well as national and local training workshops regarding the project's work. Melissa has also served as co-chair of the subcommittee that rewrote the standards for HIV/AIDS case management delivery in the district and is a member of the National Association of Social Workers HIV/AIDS Spectrum Project Advisory Board, where she also serves as a national trainer for the project. Melissa received her master's in counseling psychology from Mars College and a master's in social work from Catholic University and is a licensed clinical social worker in Washington, D.C. So as a result of hearing from our wonderful speaker, we hope that you will be able to identify strategies for gathering support for school-based screening programs, describe each of the 3 phases of the DC Department of Health program's evolution, screening program's evolution, identify challenges in developing or expanding a school-based screening program, and discuss how the Department of Health here in DC, how the staff are working on it to improve the program for the current school year. So before we get started, those of you who were on our webinar exactly 2 weeks ago, we conducted a poll, and at the request of our current presenter, Melissa, she was curious about finding out of those, if any of you, of our participants, currently have a school-based screening program in your community. So go ahead and I'll give you a couple of seconds to take the poll. Okay. Okay, based on that, we have a very large percentage of individuals who have a school-based screening program in their community. So that's wonderful to hear. And with that, I will go ahead and turn it over to Melissa. Melissa, thank you for being here.
Sure, my pleasure. Okay, so today I've kind of outlined, here's an agenda of what we're going to go through, and I will try not to talk too quickly because we certainly have a lot to get through. But I'm going to start by outlining our school-based screening program process, and then we're going to go through how the program got started, the implementation across all 3 stages, the lessons we've learned and successes at each stage, and then finally, where are we going from here? So to get started, we're going to start with the process. And I think this is really important to outline the process for our school screening program because it really provides the context for the entire program, including our scale-up and implementation. And this occurs at each school, regardless of whether they're a charter school, which we'll talk about, or a public school. So to start, DOH drafts a letter that the school's principals can send home to the parents informing them of our school screening program. It tells them of the dates that will be at the school. It provides them with an opportunity to opt their child out of the program. It's important to note that DC law does allow minors to be tested and treated without parent permission, but DOH and the DC Public Schools, which is DCPS, received very clear feedback from minors or from parent groups that engaging the parents and providing them with an opportunity to opt their child out was really important. And we found that to be true, and we'll talk a little bit more about that. But I should note that when we're in a school, if a student comes up to us during the lunch period or after school and requests that they be tested, we'll test that student because honestly we have no way of knowing if that was a student who was opted out to begin with. The school is 100% responsible for managing the returned opt-out forms because we don't know the student, so we don't know if Billy Jones walks into the classroom or not. After the principal sends home the letter, the principal and our school screening coordinator sit down to discuss the details of the program, and the principal identifies a contact person who will be the lead for implementation in that school. Sometimes this has been an assistant principal, it's been the nurse, it's been a gym teacher, it's been a guidance counselor or a social worker. Our school coordinator and the contact person at the school identify the best location in the school for the program. We need a large room which can accommodate about 50 students at a time, and it must be near a multi-person restroom. So it needs to have multiple stalls in the restroom. We've used a library, the auditorium, gyms. And finally, the school contact is also responsible for creating a schedule for our screening. We request in advance a list of teachers and the times that they'll be coming to us in our location. And this allows us to actually go and physically get the classes if they don't show up, to also mark off which ones we've seen and to track how much of the school has actually come through our program. The school contact is actually responsible, though, for informing the teachers that they must bring their students to the identified location at their scheduled time and stay with their classes throughout the entire presentation. So we're going to talk more about this during when I talk about the first year. But at some schools request that we come back and meet with parents each year, and we meet with all the parents groups. The first year we did implementation, and we'll talk more about that. But some schools have requested that we come back and meet with the parents for the second year, just because there are freshman classes that are starting and the parents are new to the program. Once we're in the school, screening occurs, and on these days, groups of about 50 students, we like to keep it to 40, but about 50 students are brought to the location where we are, and they have a 30-minute information session which is conducted by our DOH school screening staff or our community partners, and we'll also talk more about how community partners play into this. And it's important to note that we call this an information session. It is not education. It's not, it comes nowhere near to comprehensive sexual education. It's literally information, and we discuss the difference between curable and not curable, symptomatic versus asymptomatic, transmission, consequences of untreated infection, focusing primarily on chlamydia and gonorrhea. We do touch briefly on HIV, but very, 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 very briefly. We talk about prevention, and then we go into how the testing works. All students in the presentation complete a demographic form, which I'll show you in a couple of slides, even if they know they're not going to be testing, and that's one of the ways that we protect confidentiality. So all students complete this demographic form. They're all given a bag, and the demographic form goes into the brown lunch bag with the urine cup in it. They all go to the bathroom, and in the privacy of a stall, they make the decision as to whether or not they want to test. So we're hoping that some of the risk factors, some of the information about how we can cure chlamydia and gonorrhea, how you get it, and the complications if we don't cure it will encourage young people who may have put themselves at risk to actually get tested. They go into the bathroom. If they decide to test, they pee in a cup. If they don't, we tell them, turn around 5 times, sing a song, do something, and then come back out and they give the brown bag to our staff person who's there with a giant red biohazard bag. The students are then provided with information on how and when to obtain results and then are sent back to class. Then our team starts the fun process of sorting the bags and prepping the specimens that were submitted for the lab. They actually have to aliquot each specimen, taking the urine out of the cup and putting it into the test tube and labeling the test tubes and completing all the lab forms. In about 2 weeks after we've submitted the specimens, when we have most of our results in, because it can take that long to get them back from our lab, a text message is sent to those who have opted into our text messaging campaign. And this text message you can see up there informs them that their confidential results are in, that they can call us, and we just have a little message of 80% of teens show no symptoms and get tested, and that they can text, that they can reply Real Talk 1 for more information, and that's part of our text messaging campaign, which I'll also talk more about in a little bit. The text message goes out to those who opted in at 3:15 so that we're not disrupting the school day. And from that point on, the phones are ringing off the hook with students wanting their results. We also have our DIS contact students who have a positive test result and haven't called in because when we return for treatment, which we're going to talk about in a minute, we want to make sure that it's not new for the students, that they actually know that they're positive. So what does treatment mean for our program? We return to the school, and this is actually one of the most important factors for our treatment, is that we physically return to the school about 3 weeks. Last year, we'll talk about this also, it's in one of the slides, it was a little bit longer because we had some delays with the lab, but our goal is about 3 weeks after we were there doing screening. When we started developing the program, we identified barriers to adolescents accessing STD testing and treatment services, and these included transportation, insurance, clinic hours, and confidentiality. And bringing treatment to the schools eliminates all of those barriers and ensures appropriate treatment in a timely manner, which is very important. So in an effort to maintain confidentiality, we provide the school, our school contact person, with a list of students, and this list includes students who are both positive and negative, and only we, the health department, know the status of those students. When we send the list of students to the school contact person, we clearly state that this is not to be shared with teachers and should be kept strictly confidential. Even though we don't have the results of the student's test on that sheet, we don't want it left where other students can see. And we actually did have an incident last year where a teacher left the list on her desk, and one of the students saw and started to tease one of the other students on the list. So we modified our statement to be a bit stronger and to the school contact, and clearly outlined our policy around pulling students for treatment to ensure that we maintain confidentiality. We usually, when we go back for treatment, utilize the health suite, and that's the nurse's office in most cases. And we have a private room. The nurse's offices usually have a private room where students can lay down when they're not feeling well. Well, we take over that room on that day, and each student is pulled individually to the nurse's suite, and once in the private room, informed or reminded, depending on whether our DIS got in touch with them earlier as to why they're there. If they're negative, they're told of their negative results and that they were pulled because they didn't call in for their results. They are then asked to do a survey about their experiences with the program. It's a really brief survey, and we're actually using handheld computers for this, so they kind of think of it like a video game. If they're positive, hopefully they're already aware of their infection and know about the treatment day, but there are some students that our DIS cannot get in touch with because of bad phone numbers or we usually try to stick to calling until we've been to the school. We try not to do home visits until we've been to the school to offer treatment. So once a student who's positive is in our private room in the nurses suite, they meet with our clinician who completes a medical record form asking about allergies and pregnancies, current pregnancies, previous pregnancies, partners, and then the clinician administers the medication, which is oral pills. We're using oral pills at this point. We do bring juice and snacks so that the azithromycin doesn't upset their stomach. And then after the medication is provided and the medical record is complete, our DIS does an interview. Now sometimes this happens with the clinician in the room, and sometimes it happens just with the DIS and the student. It all depends on the relationship between the clinician and the DIS. And the DIS's feel for, our disease intervention specialists feel for that student. If they know that they're going to have a better conversation when the clinician isn't there, they'll ask to do it alone. And those, the interviews are to get partners. We offer partner services for our students in this program. And so if those partners happen to attend the school, then we're actually able to pull them and provide treatment for that day. If they don't attend that school, then our DIS actually go out and try to track them down. So for the schools with school-based health centers, and this year we're actually going to have 5 school-based health centers in DC high schools. We work very closely with their staff. We actually, on our demographic form, we insert a box for students to initial if they will allow us to share that they got tested and what their results are with the school-based health center. Not the nurse, we're very clear, it's not the nurse and not the school staff, but only the health center, which actually is affiliated with a private agency in DC and not the school. So we actually strongly encourage students to do this, although we can't force them to do it because we really don't want duplicate testing. So if we test a student on Monday and then they have concerns and go to the health center on Tuesday, we don't want the health center running another test on that student when we've already run the test. And additionally, the more students we can get engaged in primary health care, the better. So during the days when we are at a school with a school-based health center, the clinicians in those health centers will actually administer the medication. DOH provides the medication, but their clinicians administer the medication to the students and complete the medical record form. And the health center will also provide follow-up testing for those students who tested positive and want to enroll in that health center in 3 months' time. So if the student doesn't check the box or initial the box that allows us to share information with the health center, we discuss it with them when they come in for treatment. And historically what we found when we've worked with the 2 of our school-based health centers is that the students just didn't understand what we were asking of them, and once it was explained, they agreed to sharing that information. And it's worked out quite well when a student's come in who's positive and is treated in the health center, and it turned out they had another medical issue going on, and they were able to get that addressed right then and there. So it's actually worked out really well. So we just have one question about why the DIS have already contacted some students. So in DC, that's a good question about whether all positive chlamydias are contacted or not. And due to the volume of chlamydia, if a client has chlamydia and was tested at a private provider, then they are contacted by that private provider. And if our office only follows up to ensure treatment. The volume of chlamydia and gonorrhea cases in DC and the level of staffing forces us to prioritize chlamydia and gonorrhea assignment to DIS. And right now we have a new reactor grid, and we're looking at folks under 26, under 30, it depends on the disease, but 30 and 26. And our school-based screening program, those students have priority because of their age and the fact that they're in high school and we can get them really easily. So our DIS are assigned solely to the school screening program, and we'll talk about that. So their follow-up on the cases is only for students who are testing within our school screening program, but we'll go into more of that. So this is our demographic form, and all students complete this. You'll notice at the bottom it says secret code, and the secret code is for students to give us a password to get their results. When they call into our hotline, and we have a dedicated phone line, which we'll talk about, they give us their name, their date of birth, and their secret code, and that's how we know it's them calling and not a parent or a brother or a friend. So they would tell them to think of anything they want, something they're going to remember, and then we ask them to verify that information. We do have some students give us pushback on completing the form if they already know they're not going to test. And in these cases, we simply explain to them that this is how we count the students that we speak to. And some students are even reluctant to provide an address, and especially we find especially those students who have recently immigrated or their parents have parents whose legal status may be questionable, they're worried that we're going to inform somebody. So we work with community partners in that case who actually are bilingual, and we'll be able to explain to them that we only use the address. We only use the address if they don't call in, if their test result is positive and we can't get in touch with them any other way. Our first line of action is always to come back to the school, always to make phone calls, so it actually adds an additional incentive for them to call in to our results line so that we won't be knocking on any doors. And then at the bottom it says best way to contact you, and we explain to them that if they check the box marked text message, then they'll be opted into our text message reminder campaign, which they've actually really, really liked. So to implement, we developed some materials, and these are some examples. The next couple of slides are examples of our materials. And these two were specifically created to make students and parents aware of this screening. The poster on the left is in all the schools with the dates that we will be there noted at the bottom. There's two white boxes on the screen on the poster, and the one on the left says when we'll be in the school for screening, and the one on the right says we'll be back for treatment. We actually haven't been using the box for treatment because students have indicated that they would rather not have that information advertised. It just adds even though we do it confidentially, they just would rather not have that information advertised. We know that students notice these posters because we were in our first school for the school year on Monday, and I had a student on Saturday inform me that we were coming to his school on Monday, and he knew that because he had seen the poster. So the pamphlet on the right is folded out. It folds into a normal size pamphlet, and that's our parent pamphlet, and it's provided to each school, and it's made available in our parent resource centers. And we'll bring them if we go to a back-to-school night or to a parents' meeting. And it goes through what the program is, has frequently asked questions, has some quotes from from students who have participated, from a principal who's very supportive, and from a school nurse. So it just kind of walks through what parents would normally ask, what their frequently asked questions are. And it's worked out well because it kind of presents the program in a professional manner instead of just a frequently asked questions sheet. This is our callback card. On the left you see the front side, which has a phone number for the students to call in for their results. They can also note the date that they're supposed to call, so if they want to write down what the date is 2 weeks from today. And they can also note their secret code. Now we learned the hard way the first year that if they write their secret code and they lose the card and a parent finds it, sometimes parents call in, and our staff are adept enough to figure out when it's a student and when it's an adult and kind of navigate that situation. But it's really, we tell the student to keep it in a safe place and to make sure that they can guard that information and nobody else is going to get their hands on it. On the right-hand side is the back of the card, and that notes testing locations which are friendly to adolescents. So it lists a lot of our community partners. All of them offer HIV testing, and some of them actually offer urine testing as well. So it's an additional location where students can go for information and for testing outside of our program in the school. This is our swag slide. So we know that teenagers love stuff. And on the left, that funny-looking object actually folds nice and neatly into a box. It's about the size of a deck of cards. And we used that this summer in our summer program, and we have some left over that we'll take to schools during treatment days because it leaves, and we don't want to leave a lot of trash around the school, and kids tend to litter the boxes. But it folds into a box, and it has our summer slogan on it, which is "Gonna get it on, gotta put it on." And inside we'll slide out a package that has 1 condom and 2 breath mints, and we call those our condiments. And they were very popular with our adult crowd, and we tested with our youth crowd, and they loved it as well. And so we just we changed the design and made it more graffiti-esque, which the youth said that they really liked. And so those are available, but again, we try to reduce the trash that's left behind in the school so we don't make anybody upset. And on the right are our most popular item. And these are actually dog tags. So you can see what the dog tag looks like on the condiment. And on the one side it says tested with a question mark, and then it has our Real Talk website. And on the back side it says text Real Talk to 61827, which is our text messaging campaign that has been implemented by one of our community partners. And so students can, and young people and adults for that matter, you can feel free to do it, can text Real Talk to 61827, and then you're prompted with some questions to figure out if you've got a question, or if you just want information, or if you want to know about testing locations. And we had no idea, and I personally had no idea that these were going to be as popular as they were. I kind of thought dog tags were kind of odd and outdated and not cool, and the kids love them. We have them in all sorts of colors, and every student gets one regardless of whether they submit a specimen or not, and they wear them. I see them everywhere throughout the city. So it's just nice to be able to offer something to our students to walk out the door with. That's kind of the process, and again, we'll get into some of the detail as we walk through the specifics of our implementation. But I want to go through the development timeline because I think that this is fairly important to how we got started. We're up and running at this point in 2010, but there's a long history behind how we got here, and it's a somewhat involved history. But I think it's important to lay out for folks. So in 2006, the Bureau of STD Control really started working on the program in earnest. And I should say that the Bureau has been around forever. We've been a program, we've been a division, we've always been STD Control, and we've been housed in many different locations within the health department. So when we started working on it, we were not housed with HIV program. And so we started working on the program in 2006. And at this time, our public health lab, which we've always historically used to process all of our specimens at our public health clinic, was using the DNA probe for testing for chlamydia and gonorrhea. So the Bureau really began pushing the public health lab to institute NATS testing, which was quickly and had already really become the standard of care elsewhere. And this would also open the doors for alternative site testing. So we actually started exploring the cost and the feasibility of using other labs so that we could start using NATS testing. And that idea of we're going to take our business elsewhere really prompted the public health lab to convert to NATS testing. So additionally in 2006, we have an active community coalition that actually started working with the STD Bureau in the 80s. And our community coalition consists of community partners, community members, and other governmental partners, and it's worked on various projects including advocacy issues. Well, the community coalition was fully engaged on this project of getting school screening into the schools and was really, really committed to seeing it happen. So throughout the development process, they were active in engaging other community members in these ideas, advocating to government leaders, and they even wrote an op-ed piece for the paper about the program. And that's an important component because they could step in and advocate to some of our political stakeholders where members of the Bureau couldn't, because we're government employees. We can't go to the City Council and say, I think you should do this. But our community partners can, and they are loud and very vocal. So we actually happen to be able to activate some of our more vocal members of the coalition and really get them motivated to move this forward. Additionally, in 2006, the Bureau hired on several staff. So we filled several vacant positions. And one of those positions, she had actually worked on a similar program in another city in Philadelphia. So she brought knowledge as well as some manpower. And the other staff who were hired also brought additional manpower to help with the program development and implementation. So that was huge that we were able to fill some vacancies so people weren't doing 2 and 3 jobs and didn't have time to focus on the development of this program. And finally, in September of 2006, we had an election, and our local elections happened, and we had a change in leadership. So we got a new mayor, new council members, and which meant new leadership at public agencies, which was set to take hold in January. I should say we had an election yesterday, and we now have another new mayor, and I'm sure we're going to have changes. But hopefully we've hit the ground and have enough baseline to prove that we should stay where we are. So that was 2006. 2007 was an extremely active year. As I said, in January, the new mayor and the new council members took office, and immediately changes in leadership among DC agencies occurred. And he also announced immediately plans to take over the school system. The school system had been run by a superintendent and a school board, and he was going to take it over and put it in the mayor's office and hire a chancellor. So throughout the spring, he worked on the implementation of that plan. February 27, 2007 is the day that NATS testing came to DC. That's the day the Public Health Lab went fully operational with NATS testing. And in March, I was asked to attend a health fair at a local charter school, and by the school nurse at that charter school, and I told her, we've just started doing urine-based testing. Do you want us to do it at your health fair in addition to offering information? And she thought it was a great idea, went back to the administration at the charter school, and the charter school administration agreed, but said only if the students had parent permission. So they actually set it up where students could get a permission slip, and if they brought that permission slip back, they got their hand stamped and they could come through and get tested by us. During that 3-hour health fair, we had 48 students get tested, and we had 6 with a positive test result, and all were asymptomatic. So that really laid the groundwork for what we knew we were going to find in the schools. So that was a great first opportunity to get into the one school through a health fair, which, by the way, is a really non-threatening way to do it, to offer it at a health fair, because you are an entity coming in with a lot of other public entities and nonprofits, and it's not that the school is doing it, it's just that they're offering all these other services as a part of that health fair. And even if they have to have parents' permission just to make the school okay, you're still going to have students who are able to get tested. So it was a great in. In March of 2007, we had our director of the health department also sent a letter to the current superintendent, who hadn't been ousted at this point, requesting support and implementation of the program. We got a letter back stating that the disease burden was recognized by the superintendent, but that he felt the burden of testing should be with our managed care organizations and the parents, not the school system. So politically, it was a difficult time because the mayor hadn't taken over the schools, and officials knew there were possible leadership changes ahead, so I think they were a little reluctant to step out. In June of that year, we engaged with SHAPE, which is the Senior High Alliance of Parents, Principals, and Educators. And that's a strong parent group. And so one of our coalition members had been attending those meetings and asked if DOH would go in and do a presentation for SHAPE. And we did, and SHAPE had questions and gave us feedback about the program, but was generally very, very supportive about it. So they've continued to be one of our allies throughout this whole process. And we'll talk more about how they've played into this process. Additionally, in June, that's when the mayor brought on a new chancellor in DC Public Schools. In August of 2007, you can see it was a busy year. In August of 2007, we engaged the school nurses because we knew we were going to need them to be supportive of the program, or at least know about the program, especially since we wanted to use their nursing suites to do treatment. So our medical epidemiologist went and spoke with the school nurses and reported that their biggest fear was that their workload was really going to increase. And it's important to note that our school nurses are hired through our Children's National Medical Center, our local children's hospital, but that funding comes through the Department of Health. So there's a big coordination piece between our counterparts in the health department and the school nursing program out of Children's National Medical Center. Also in August, our coalition members began meeting with these newly elected city council members to discuss the idea. All of the city council members that they met with expressed strong support, but no one wanted to publicly verbalize that support. And they were also a little hesitant because they thought we were asking for money. We actually weren't asking for any money. We just wanted the political power to be able to move ahead. interestingly, in September, the charter school where I had done that health fair in March, way back in March, and we had the 6 positive students, our medical epidemiologist discussed that at the June meeting of the parent group, and the charter school happened to be at that meeting. So they heard the discussion and the data about that health fair that we attended and tested at, and approached the health department saying that they were interested in offering testing for their entire school. Is this something we could do? And of course we immediately jumped on that opportunity to work with the charter school. And just to make sure everybody knows, charter schools aren't governed under DC Public Schools. They're their own local education agency in DC, so they're governed a little bit differently and have a bit more autonomy to do what they want to do, basically within the realms of reasonableness, but they have a little bit more autonomy. So they approached us and asked if we would do testing, and we of course said yes. So we finalized our protocol for the program, which is kind of our guidebook for how things are done. It outlines all the procedures with how the program is going to be implemented, and it's updated continually, even to this day. It's really a living document, and as we make changes to the program, it's updated. So it's always here in case somebody wants to see how it's done, or somebody new comes in, that they kind of have this walking guide of how to do the program. In fall, we really started planning to go into the charter school, and in November our first round of testing occurred. And I'll talk about why we had a first round of testing when we talk about what happened in this charter school. But I can tell you that we immediately recognized some challenges and had to kind of pause, take a break, and then go back, address those problems, and then go back and fix them. So that's 2007. And in 2008, we did our second round of testing at the charter school in February. And at that time, our medical epidemiologist was presenting some abstracts on our testing efforts in the high schools, and got really positive feedback when he was presenting those to various folks, both locally and then around the country as well. In April of 2008, at this point, the Bureau of STD Control had been merged under our HIV administration, and we had a new director who had been hired in October of 2007, a very progressive thinker, and she provided full support for the program in spring of that year. She was finally able to kind of get her feet on the ground. We were able to get some FaceTime with her and explain the program, and she loved it. Also in April of that year, the big health department got a new director, because as I said, we had a new mayor, and sometimes they clean house, and they did, and we got a new health department director as well. But our director at HOSTA engaged the chancellor of schools, who had been there almost a year, and was able to obtain support. So the chancellor liked the idea, wanted to work out some of the details and get it going. And so she identified an office within DC Public Schools to work on the project, and that's the Office of Youth Engagement, which has been invaluable to us. They have just been a wonderful support system and really helped get this off the ground. The Office of Youth Engagement works on all issues and factors that can prevent a young person from being fully engaged in the learning process, with health and mental health being two of their biggest focal points. So it just was a natural fit, and their staff has just been a great supporter of ours and really helped facilitate this. Ironically then in May, one of our staff members here at HOSTA was at a meeting of all agencies that work with youth in the city. And it was held in the mayor's office, and he was describing the program because the chancellor had given her support, and so he was describing the program to other folks in the room. And at that point, the mayor happened to be in the room and fell in love with the idea, thought this was a great idea, and said, "This is wonderful, go into the schools, absolutely, but I want you to start before you go into the schools with my summer youth employees who are hired for the summer." And that program started 6 weeks from the point that meeting happened. So we're working with our summer youth employment program, which is a whole nother webinar for a whole nother time, because it's a completely different topic. But he threw his support behind it that fully, saying yes and even start now. But you can see it's taken us 2.5 years to even get to that point. So in the summer of 2008, we met with DCPS and SHAPE, that parent group that I mentioned, and identified 7 public schools for the first year. We wanted to start small. We didn't want to go big. We wanted to make sure that our staff, we had our I's dotted and T's crossed. And we selected schools based on a cross-section of the city. So we looked at high morbidity areas, we looked at schools that had principals returning, and we wanted to make sure we weren't stigmatizing one school in one particular area. In DC, our east of the river communities, wards 7 and 8, tend to get a bad rap. They have high poverty, high drug rates, high infection rates, and we didn't want to just do schools in that area. We wanted to make sure that we were broader than that. So we picked schools from across the city. Again, when we get into the specifics of that year, we'll talk more about that. But in the fall, our program met with parent groups at each of those schools, and efforts were made to ensure that we met with the PTA or some form of it and addressed any questions. There were questions, and all were answered. And a few parents were really vocal against the program, but once they really understood the program and understood that they had an option to opt their child out, they kind of backed off and felt more comfortable with it. And that's what we found, that anyone calls and objects about the program, we remind them you can always opt your child out. We encourage you to exercise that right, and that kind of quiets them down. So along the way, we made sure that SHAPE, our parent group, was up to date with what's happening. They were really strong advocates and had great ideas about the program and how to engage parents and schools. So it was really vital that we kept them at the table. And we've continued to do that throughout the year. We go back at the end of every year and offer them an update on how the school year went and what the data is for that school year. So in 2008 and 2009 school year, which we completed, we went into 9 senior high schools, and of those 9, 6 were DCPS. And we'll talk about why only 6 when I mentioned 7 in the last slide. So 6 of the 7 DCPS schools were able to implement the program. We also had the charter school that we had been working with, and we had 2 special education schools. And those 2 special education schools approached us about health education, and we in turn offered the screening program, and they jumped on board. That final one school, that final one DCPS school, we didn't really have the support of the principal. And again, we'll go through more of that later. It's important to note that even with central office buy-in, and by central office I mean central office at DCPS, at our DC public schools, and letters from the chancellor stating that the program is going to happen, we still had resistance from principals. And that resistance doesn't have to be an overt objection to the program, but it can just be ongoing struggles with scheduling and cancellations at the last minute, which can make it eventually impossible to fit this into the school year. And that's what we eventually ran into with one of those schools, that they never came out and said absolutely not, but they just kept canceling, and they just kept coming up with excuses why it wasn't going to work until it finally was just too late and there weren't going to be enough kids at school to make it worth our while to go in. In 2009, full implementation began. So that's really the year that we went into all of the DC public high schools, which is about 20 DCPS high schools. And we spent a lot of the summer before that planning for that, coming up with schedules, working with the DC Public Schools, the Office of Youth Engagement, to make sure principals were aware. And it's a short turnaround time. Principals, the contract for principals is July 1st, June 30th to July 1st. So we have turnover. Every year principals are let go, and every year they hire new principals. So we're starting at scratch, with a couple of our principals. So it's a mad rush in the month of July and the beginning part of August to make sure that we've got everything all set for the school year to begin. So with program development, our Bureau identified chlamydia and gonorrhea as a priority. That's just the way it was. This was going to be a priority, and this was something that needed to happen because we were seeing really high morbidity and a lot of asymptomatic infections. We have our existing program staff. So we had originally, with our first year of implementation, we had 2 DIS, 2 disease investigators assigned, 1 clerk, and about 50% of my time, and at that time I was the education coordinator. And our school-based screening coordinator who came on board, her position was actually covered by a different administration for the first 18 months of the project. So it was nice. She was fully on board with us and was working with us, but fiscally our administration didn't have to cover the cost of that FTE. So also historically, I should say that we were able to use some unused monies to cover some of the costs for the initial startup. And I'll go over budget a little bit later on. And we no longer have unused money, so that's no longer happening. So we can talk about how we're actually funding the program now. We identified supplies. And that's huge. You need to make a list of all the supplies that you're possibly going to need, and that includes everything from brown paper bags to urine cups to pencils to paper to print out the demographic forms to biohazard bags, hand sanitizer, very important. And we ordered all of those supplies, and we actually secured a separate phone line for the call-in number for students to call in to get their results. We also, and this is something that worked really well for us, we traveled to New York City in the fall of 2007 to observe their program. So they were already up and running, as was Philadelphia. Philadelphia provided us a lot of technical assistance, and New York actually let us come up and see their program. So we went up and we spent the day with New York City and shadowed them and did some of the work and really saw it come to life. And we took parts of their program, we took parts of Philly's program, and then we created our parts of our own program and kind of came up with a hybrid of what works here in DC, because we're a little special. We're a little different than other places around the country. What were some of the challenges that we ran into? A lot of the preliminary work within our agency occurred with really trying to get people on board. You would just assume that everybody in the health department's on board with this, but they're not. There were concerns about parents, about working with the school system, and just generally how this was going to be implemented. Working with the charter school at that health fair, we ran into the initial roadblocks with the superintendent, and his response was the burden of testing should lie with the MCOs as opposed to DOH or the public school system. Work kind of continued on this in the background because it was an election year, and we were hopeful that we'd be able to get some momentum once the election passed, and in fact we did, as I discussed. School nurses have some of them have jumped right on board with us, and some of them are a little bit hesitant because their workloads are really high. They've got a very high workload. So we had to make it very clear that the burden of testing and coordinating would not fall on the nurses. And even if the school system had jumped on board in 2006 or early 2007, there really wasn't a dedicated office at that time for them to work with us. And that was really important that we had somebody on the inside in DC Public Schools to help with the coordination and the implementation, and to let principals and teachers know that this is happening and this is something that's coming down, that the central office and the administrators feel is really important, and help them understand why it's so important and how it impacts student learning. That if students are preoccupied, and I know everybody knows this, but if students are preoccupied that they may have an STD, they're really not focused on school. And if we need high test scores and we want students learning, we need to do what we can to eliminate those barriers to learning. So our pilot year and our pilot school. So as I said, after the health fair in March of 2007, that charter school was open to testing, and the nurse was super supportive and actually wanted to assist as much as possible. She was wonderful. Unfortunately, she's no longer there, but she was a wonderful ally of ours. So initial meetings were held, and the school decided it actually wanted to train youth enrolled in a special health track, and that these students would serve as role models in the school and assist with the day of programming, such as packing bags, handing out materials. So we did that. We tested those students first. And then we went in for the first round of testing in November. And it was during that time that we realized that not all students were coming down to the auditorium where we were located. We found out from students that teachers were saying, you don't need to get that test, you shouldn't be having sex, so why do you need that test? This class is more important, so I don't want you going. So at that point in time, we halted testing, and we regrouped, and we actually conducted 2 training sessions with the teachers to discuss the integrity of the program, the process, why it was created the way it was. And then we actually had them sign an agreement stating that they would not influence students either way. They would just simply say, we have to go to the auditorium for an assembly, and they would come down and stay with their students, but not influence them. So we returned to school after the holiday break to provide treatment for the group of students who were initially tested in November, because we did test a bunch of students and we did have a bunch of positives. And then we continued with screening in February because we hadn't seen every student, and the school thought it was important that we come back. I have to say, after we had them sign those agreements, it went much better. Students came to the auditorium, and really the largest issue we ran into was classroom management, with students acting up. And really, anytime you bring a lot of students into one location, you run that risk. And teachers sometimes left and took advantage of a free period, so students did tend to get a bit unruly. And we returned to the school in February after the February screening to offer treatment. And this team consisted of the school screening coordinator, 2 DIS, myself. We had an Internet Partner Notification Coordinator here who came with us to provide manpower, and we had 1 clerk who was helping with aliquoting and then that ever-important data entry. So we had an on-the-ground team that was dedicated to being there for both of those times. And we really just pulled people from our current staffing. There was really nobody new except for the school screening coordinator who, as I said, her FTE wasn't even covered by us at that point. So what happened when we went back to that school? So we know that about 72.5% of the students received our information, which we think is pretty good. Anytime 70 to 80% of the kids receive information, we view that as successful. We strive for about 65 to 75% of those students who heard our information giving us a urine specimen. And what's interesting, you'll notice in red that our allied health students who have a health focus actually had a really high positivity rate. They had 21%. And that really struck us because we thought they had a health focus, they might be more health conscious, they might have heard this more, they might be practicing prevention a little bit better than maybe their peers. But what we came to find out from talking with some of the students is that they took that health track because the teacher was easy, not because they were necessarily interested in health. So they were just your average risk students who all happened to kind of be grouped together. It was this data that was actually presented at a mayor's meeting and prompted him to throw his support behind the program. So we really used the data from this charter school, which we still go into, to help us move into other schools. So it was really the impetus. So getting into one school and finding one school that's willing to think outside the box is really super important. We do surveys with all of the students, and these were some of the results that they gave us from that initial first school. You can see that why did students decide to get tested? They were sexually active and they wanted to make sure they were safe. Their friends had decided to take the test, so they thought they would too. Even though we protect confidentiality in the process, they were all, they're still talking about it. They still say, did you take the test? I didn't take the test, right? And they still talk. They're teenagers. So we use some of their comments and feedback to actually help shape the program. So one of the questions is, what can we do to improve the program? They stated that we need to call the students first if they're positive. So in that particular school, when we went back for treatment, we had a situation where a student was positive and didn't know because we didn't call them ahead of time. If they didn't call us, we just went back to school and pulled them, and they were very, very, very upset. And so we've learned that letting them know ahead of time allows them to integrate the information and then take ownership over where they get treatment. They're actually able to go to their own doctor, they can come into our clinic, or they can wait for us to come back to school, and that gives them ownership over the process. So we learned that from these students, which was great. So some of the challenges that we had in that pilot year, the school was chaotic, and scheduling within the school was chaotic. So this particular person who was our contact person was the coordinator for health at this particular charter school, which has several charter schools in the district. And so she's really an off-site health coordinator, and she really wasn't familiar with the teachers and the feel of the school. So it made it difficult when she tried to coordinate or pull the students, and that's when we realized it's super important to have somebody in the school who's responsible for the schedule because they know the school culture. We also learned the hard way that it's important to send the message to teachers that this is not optional and their opinions are actually best left out of the process. The lab was not used to the increase in volume, and it took quite a while to get labs back from them. At that point we changed how we managed it internally and actually had a separate fax number for them to fax our results to. We're still getting results via fax. We are switching to electronic reporting eventually, but we still get them via fax. And so we have a separate fax line for, we had a separate fax line for our school screening program. And it was just challenging to get the public health staff to understand the time-sensitive nature of this. All results are time-sensitive, but this one especially so when we have to be back in the school. We also learned that teachers have to stay in that room with their students. With longer, highly interactive presentations, sometimes it's important for teachers to leave so that there's a safety element in the room and students can ask a lot of questions. In this particular case, because that's not how the program is structured, it's really important that they actually get into, they're able to stay in the classroom and or in the area that we are and assist with classroom management. And then there are, despite our attempts to engage parents, we still had a few instances where they were upset. In one case, a student called a parent to let them know that they had tested positive and received treatment, and the parent showed up and proceeded to, I couldn't call it a heated discussion because I think she just yelled at our clinician about providing treatment without parental permission. And they had a really long dialogue, like 45 minutes to an hour. And after that, she calmed down and understood the program and really just wanted to know then how she could talk to her child about sex. She really just wanted to be equipped with that. So we learned that. We learned that at that moment in time as well. The lessons that we learned is engage the teachers, and engage the teachers to make sure that they know that this is not optional. And we really, need the principal to be on board with that too. And we haven't had as many issues in our public schools as we did at this particular one. We have a results line where students can call in. And at this first school, it only had one line. It didn't roll over. So if somebody was on it giving results, it rang busy. Or if somebody wasn't there, it didn't go to anybody else's phone. So it now rolls over 3 times to 3 different lines on 4 different phones. So there's 4 of us in the office that can actually, it rings at all of our desks at the same time, and we can pick it up, and 3 kids can be calling in at the same time, and that was really important. We piloted partner services with the school and realized that it was important to have a mechanism in place to capture this data. We didn't do a great job of capturing this data that year. We know the reinfection rate was high among adolescents, and to identify their partners was important, and we now have a system in place for capturing interview and partner records within our data management system. And we also learned that the groups of youth need to be small. At one point we had 99 students come in for a presentation, and that was just a bit too large. So we really encourage it around 40 students. This allows the message to be more personal, a little bit more interaction, and it really helps the students stay focused. We also learned getting information out to the parents through summer mailings and giving principals advance notice was important so that we can so that they don't feel like they're being disrupted at the last minute. So we've implemented those structures where all of that happens in the summer. And finally, like I mentioned, students have different reactions to being positive. Some students cry, some students have a flat affect, and we learn that it's important that students know ahead of time. So our DIS make every attempt to contact the student before we go back to school, as I said. So that was our pilot year, and then we expanded. We expanded to include DC public schools, and this is where we expanded to attempt to include 7 DC public schools. And as I said, the chancellor signed on, the mayor signed on, our 7 schools were identified across the city. We internally identified a team that would be working on this project. We had 2 DIS to do the presentations and follow-up. We had 1 clerk for data entry and answering our results line. We had the coordinator who was arranging all the schools and the meetings. And then I was there about half-time just helping wherever I was needed. Coordination, parent meeting, on-site assist, however they needed me. We faced challenges, absolutely. Meeting with the principals was one of those. A few of them were not thrilled, and they figured just get in and get out and get done. And so we worked with their needs. And in one case, we had one principal who was like, you are not coming into my school and disrupting it, and it's a very high-achieving academic school. And we worked with her. She said, fine, you can have 1 day. And so we brought in folks, and we did that entire school in 1 day. We did 1 presentation in the auditorium and 1 presentation in the gym at the same time, and we got through it. And she's now one of our biggest supporters. So we know we get to her at the beginning of the school year before they're kind of really get deep into their academics, and we do her in one day, and she is fine with it. She loves it. She thinks it's great for the students. So she's a big supporter and is actually the principal quoted in our pamphlet. So the principals who were resistant, they again made coordination challenging in setting up meetings and giving us a contact person and changing the screening dates. Finally, there were no school days left for that particular school that we had a lot of challenges with, and so we couldn't actually get into that school. And that was that one school, so we were in 6 but not 7. And we worked really hard to meet with those parents. I attended PTA meetings, and really I was prepared for a lot of resistance, and we really weren't met with all that much resistance. I was pleasantly pleased with it. And this is what panned out. So we went back to our pilot school for the second year, and we saw a decrease in infection in that particular school. It went from 9% to 6%. But we also saw and screened about 200 fewer students, so I'm not sure how that impacts our positivity rate. But we were pleased to see a little bit less of an infection rate. Among the 9 schools that we tested, 66% of the students, we saw about 66, of the students we saw 66% submitted a specimen. And we had a positivity rate that ranged from 3% to 18% depending on the school. And interestingly, the school with the 18% positivity was tested right after the Thanksgiving holiday and had a lower attendance than even we had expected. So who knows what their positivity rate would have been had all the students actually come. 11% of the students who were positive had an infection within the past year. And of the 9 who were not confirmed treated, a bunch of them actually lived out of state. So those reports went out of state, and we did have a couple who were incarcerated. So they received, they actually got tested and treated in the jail. So what were our challenges in that first year? Attendance has continued to be a challenge, was a challenge, and still is a challenge. On any given day at certain schools, 20% of the kids may not be there, and we know that there are high-risk kids, and we're currently exploring how we can engage them in testing. We had multiple disruptions. The school forgot about the testing. We had fires that were set in the school and we had to evacuate. It was senior picture day. I mean, you name it, we had disruptions. We had classroom management issues. Cell phones is the hugest. The kids are actually listening to music on their cell phone or iPod. Kids were throwing things. Not all schools. There were some that were wonderful, but we did have our share of disruptions. And then they would assign a contact person to us, but we didn't realize at the time, we know now that it really wasn't the appropriate person. So they wouldn't have access to schedules, or they wouldn't have a relationship with the teachers. They were hard to get in touch with. And so we've really learned that finding that right person in the school to be your contact person is key. And we tend to try to go back to that person year after year because they know the program, they know how to make it work efficiently. Principals need as much warning as possible. So we informed them over the summer. We sent them, we tried to tell them when we were coming in. Like I had said, the contact person is super important. Parents want to be engaged, and most of their concerns were around, you're going to give my kid medication without my knowledge. What if they have an allergy? They may not know they have an allergy. And so we were able to address those concerns and inform them that we have a clinician on site, and so that isn't just me, administering medication. It's actually a doctor. And as I said, we just need to provide easy access to the program staff. So I freely pass out my phone number and tell the schools, you can call me, you can call our coordinator, and we'll gladly deal with any irate parents. That's our job, not their job. So implementation into all, so our first year where we were in 60 CPS high schools and 3 other schools set the stage with our data. So it really gave us some good baseline data, and then we were able to expand. We wanted a year under our belt to take a look at staffing here in our bureau, take a look at supplies, how this was going to work all the kinks out, and then go big. Well, we didn't want to go into 20 schools the first year and have it turn into a disaster. So we were very thoughtful about starting small and then expanding. In order to expand, we knew that we would need 2 teams because there were times when we are in 2 schools at the same time or providing treatment at the same time. So we actually pulled 4 DIS from our field operations unit. they're not so happy with us, but we did pull them. And they're responsible for the implementation on screening days. They get to the schools, they set up, they conduct the presentations, they prep the samples, do all the paperwork. We had 2 interns, one who was paid and one who was for credit, and each worked 2 days. Our paid intern assisted us in a clerical capacity by doing a lot of data entry, and she's great actually for on-site urine prep. And our intern for credit was a graduate level intern, and she assisted with some of the coordination of the program, follow-up with students, and some data entry because quite frankly everybody does data entry because there's such a high volume of it. Our staff assistant, we do have a staff assistant, is responsible for assisting the coordinator with meeting schedules and meeting prep, data entry. She answers our Dr. B hotline for results and deals with all the supplies. The coordinator is responsible for all of the prep work with the schools, scheduling the schools, meeting with parents, ensuring letters go home, attends screenings on the first day just to make sure everything's going smoothly, and then fills in when necessary. And she's also responsible for the data entry and making sure that our positive students are followed up with. And then me, and I'm kind of oversight. So the higher level coordination with the school, I attend parent meetings when we need it, and fill in. I mean, I'm out there collecting urine when they need the help and doing data entry as they need the help. So the schedule was set in the summer, and we sent the posters to the school and pamphlets. A letter was sent from the chancellor to all the principals, and in August the coordinator provided the schedule to the principals and asked them to follow up with scheduling with conflicts. In late August, meetings began to happen with the first 3 schools, and we felt it was important to hold face-to-face meetings that first year with the school just to make sure everything was getting off the ground. We also ensured that we went to all the back-to-school nights. Usually they gave us about 5 minutes to explain the program and answer questions. And sometimes they just gave us a table to put out information, but we were there to make ourselves accessible. So we would also attend PTA meetings if that's what they preferred. When we developed the schedule, our teams came to the conclusion very early on that we alone would not be able to handle the volume of testing in the schools without assistance from our community partners. So we asked 5 of our adolescent providers in the community to commit to coming to 2 schools each. They were asked to send at least 2 staff to the entire screening. Some of these community partners were already working in the schools, so it was a natural fit. They wanted to go to those schools. We allowed them to hand out their materials. We highlighted them as a testing location. Some of the community partners did the presentations, which was great. Some of them just wanted to help behind the scenes. But it basically gave them access to students, which they otherwise would not have had access to. So they appreciated that. And finally, we wanted to help more students call in for their results. So although we haven't measured it yet, we know that about 30 to 40% of the students call in for their results, which is average, but it's lower than we'd like. Most forgot or figured that no news is good news, which in fact is actually true. But this past year we implemented our texting campaign, which I showed you at the beginning. So we text the students who opt in that their results are ready, and they call us, and the phones ring off the hook. So what happened during our second year? You can see here that we only saw, we think, about a little over half of the students who actually attended DCPS, and we know that there were issues with attendance and some scheduling in the schools. Of the students we saw, about 65%, so that's kind of right where we want to be, submitted a specimen, and we had 6% test positive. And it's important to note that that did vary. We had schools, like I said, with the earlier year, we had schools with very low testing positive percentages and very high positivity rate. We had a 92% confirmed treatment, which we're super proud of, and we had 137 students give up partners to us. So we actually had 137 partners who were brought to treatment, which was wonderful. So that's something we'll be continuing this year as well. Some of the challenges is that the schedule was packed, and this posed a problem in the second half of the year. We tried to spread the schools out over the school year, but that backfired, and this year we're not doing that. We had 2 major snowstorms in DC. in February, back-to-back in 1 week. So it basically shut down the schools for 2 weeks. And then there was testing, standardized testing in April, so we were not able to enter the schools during the month of April. So, and then after April, prom happens. And once prom happens, seniors don't go back to school, and so basically that shortens your time. So we learned the hard way that we need to be into the schools and done with the schools by the time February ends, and that's what we're doing this year. So it's even more of a packed, crazy schedule. Also during this year, we had 2 DIS have babies. So we had to have other people step in and cover. And our field operations staff was very short-staffed because we kept pulling people from them while folks were out on maternity leave. Our staff got tired. It's really draining to do 5 presentations in a day along with lugging all of these materials and the urine prep. And there's no easy answer to addressing this. This year we're trying to modify the schedule so they're either not their first period or not their last period to kind of shorten the day, but we're not sure that that's going to work at every school. Our community partners, which we're so grateful to for them helping out, but at times their help was a little inconsistent. So we provided a training at the start of the year for our partners so they'll be well versed on the presentation and the data forms, but often new staff would show up at each school, so it required on-site training. So we had to be prepared for that. Or they would have to modify their schedule and only come for 1 day. And there's really no motivation other than access to the schools and learning how to do the testing because they're not getting any money from us to do this. So we are hoping that the expansion of our gonorrhea screening program where we can send more screening to our community partners and they can do it on site will be continued motivation. As I said, principals were a challenge, so we're hoping the second year that the principals will know us and they'll be a little bit more willing to work with us. But again, that biggest challenge is attendance. So we're talking with DCPS around how we can engage our high-risk students who are out of school, and we're working with other governmental partners in DC around how to engage these out-of-school kids. And they're not necessarily out of school, they're just not showing up on that 1 day or those couple of days. And our lab continues to be a bit slow with the turnaround time. So while we want to be back in the schools in 3 weeks, it doesn't always happen. So we were a little slow getting back. These were our surprises where students receive testing. When they call in, they get the option of where they can go for testing, but the majority of them selected the clinic. Now it's important to note our clinic is only open during school hours, which meant they either had to wait for a day when they had no school, and we were open, or they had to cut school. But what they basically told us is that once they found out they had the infection, they just wanted to get it out of them and they didn't want to wait. The goal was to return in 3 weeks, but sometimes it turned into 4 or 5. So we're working with working through this process to get back to the schools a little bit faster. And we also had to develop some infrastructure at the clinic to make sure that our students were fast-tracked for treatment through the clinic. So we had to work with our clinic staff as well. And students had testing memory. So we know that students remember the material from year to year, which is kind of cool. So they remember us, and they remember some of the answers, which is nice. So let's talk just real briefly about data, and then we're almost kind of done, and we can open it up for some other questions. So this chart is from 2005 to 2009, and the reason I wanted to show it is that it really shows the significant increase in the number of males that were diagnosed with chlamydia. So you can see it was really low in 05 and 06, and then as we expanded our program and went into the school, we were able to increase the opportunities for the men to be screened. And that was really great. So we actually increased the number of men who were able to be tested and then diagnosed. And in this slide, the reason it's important is you can see that the difference between the number of people diagnosed with chlamydia between ages 15 to 19 increased significantly. So what we had seen this is gonorrhea, sorry, not chlamydia, with gonorrhea. So historically in DC, we used to have 20 to 24-year-olds infected with gonorrhea more than our 15 to 19-year-olds. And you can see in like 2005, 2006, and even 2007, it was pretty close. But really in 2008 and 2009, we significantly increased the number of diagnosed cases of gonorrhea among 15 to 19-year-olds, which we thought meant that we found otherwise undiagnosed or asymptomatic infection. So it really showed that the screening program really opened up screening to a population that may otherwise not get tested. So I'm sure the big question is, how do we pay for it? And I wish I had a brilliant, easy answer. But DC uses a combination of federal grant monies and local dollars. The federal grant monies basically pay for salaries, and the local monies we use to supplement salaries, but also to fund supplies and other aspects of the program. So you can see what we spent on supplies. You can see that our laboratory costs are pretty high. It's about $25 a test here in DC. And the lab also purchases, that includes the purchase price of the test kit. So the lab purchases the test kits for us and gives us the urine cups. So that's a savings to us, kind of, I guess, in that we're not purchasing them, but it's included in that $25 a test. At this point, we don't have a program budget. We don't have any dedicated funding for this program. We pull staff from other programs. We use local monies for supplies, and we're trying to figure out how we can have a dedicated funding stream, but times are tight, and I mean that's just I think the reality for all of us. So you can see how it kind of breaks down for the staffing and salaries. Like for most of your programs, salaries is our biggest expenditure here in DC. It's where a lot of our monies actually go to. All right, so our next steps, and I'd like to include wishes with those. Where do we go from here? One of the challenges, this is kind of really exciting stuff, with one of the challenges that we've had with treatment was identifying a doctor to go with us. And we were really lucky that our medical epidemiologist is still a practicing clinician, and he was very, very, very invested in the program and went with us. However, as we go into all DC public schools, we can't pull him from his work, several times a week. So we identified a volunteer clinician, actually through our medical epidemiologist, who had volunteered at one of our CBO sites, and she was trained and took a test and observed our process and became a part of our program. But still, this wasn't enough. So we've now started a partnership with one of our largest medical providers for the uninsured and underinsured in DC, and their director of adolescent medicine is a big supporter of the program and is also the medical director at one of the school-based health centers. And together, we've identified some external money that will go to that CBO so that they can assist in paying for the doctor's time to have them go out with our teams. So they have clinics throughout the city, and doctors at those specific clinics will accompany our team on treatment days and administer the treatment, and then be able to give that student a card saying you can come and see us in 3 months. So again, we've got school-based health centers that are going to help us with treatment, and we're going to be working with them closely. So that's eliminating some of the burden around our clinicians, and so hopefully we'll see how this partnership works. This is the first year that we've had that. So we've also been discussing how we can incorporate HIV testing as a part of this program, and confidentiality is a big issue with that. We've discussed it as an option with screening. We've discussed offering it to the students who test positive and come in for treatment days, or having our community partners go into the school after we leave to provide testing. And at this point, with our community provider who's going to provide treatment, we're actually going to test it out on treatment days. So this is what they offer as a part of their services. So we're gonna give it a try, but confidentiality is our biggest concern. And so we also, we continue to look at how we can make the screening routine. We offer it during the school year, we offer it during summer, we offer it at CBOs, but we want to make sure that that testing memory sticks around for young people and that this just becomes routine. So those are some of the things that we're looking at. Oops, sorry. So my wish list is if I had all the money in the world, I'd like to expand the program and address reinfections. We know that our young people get reinfected at an alarmingly high rate, and so I would love to be able to expand the program to include more than point-of-care counseling, which is what's currently happening. So for our students who test positive and have more than 1 or 2 diagnoses within a year, maybe they get referred to a different program, or we have a social worker on staff who can work with them around what's happening that's leading to these infections. Is it a lack of knowledge? Is it, a relationship? All of that concern. So we're playing with how that could look, and we're looking at other funding streams that might be able to help expand that program. Is that internal here to DOH? Is that external with a community partner? What we do know is that when a young person tests positive for HIV, they're immediately wrapped into care. And in DC, we view the testing for chlamydia and gonorrhea as really a primary prevention for HIV. Less than 1% of our HIV infections are among teenagers, so we hope that through testing and treatment of chlamydia and gonorrhea and behavior change, we can have an HIV-free generation. And so, if young people are getting wrapped into care, why are we waiting for them to get infected before they get wrapped into care? Why aren't we doing something earlier? So we're looking at that. We haven't worked anything out. And we'd like to look at community involvement and then expanding our parent components to really take a look at what we can do. So that's kind of our program in a nutshell. I'm not sure, Sandra, if you want to open it up for questions or.
Sure. So you're free to enter questions into chat. Or given that we have a manageable group, if you will, in terms of number, if you have a question for Melissa, you can individually unmute your line by pressing *7 on your phone and ask her a question. And I apologize that we don't have very much time for questions, but we'll try to get in as many as we can.
Hello.
Yes. I can hear you.
This is Ina Asmadi. I'm calling from the New Mexico Department of Health here in Albuquerque. We are creating a program using school-based health centers here in the state to kind of normalize chlamydia screening by using those clinics that are already in existence at different high schools and combining that with a social marketing campaign. And I'm just wondering, we're going through our budget, and so far it's a pretty cheap project. I'm wondering if you have ever considered using social marketing to increase student interest kind of over the course of the year versus kind of like these large mass screening events as a cost-saving measure?
Yeah, that's a great thought, great program, great question. We have a whole kind of capacity building social marketing department here that's always looking at ways to engage the community, and they're specifically now working around adolescents. So they're working and they'll work collaboratively with youth organizations as well as with our unit to look at how we can increase awareness, as you said, and then help to normalize those behaviors. So I'm not sure it'll take the place of kind of our blitz screening in each of the schools, but right. It might bring them to testing more routinely.
Mm-hmm. Mm-hmm.
Yeah, that sounds exciting.
Any additional questions? You can either use the chat or press *7 on your phone to unmute your line.
Hello?
Yes, go ahead.
Hi, I'm here in Douglas County Health Department in Omaha, Nebraska, and we would love to be able to participate in this type of testing, but we really do live in a very conservative community, and we have very high chlamydia rates and gonorrhea rates. So I'm in Omaha, Nebraska, but we're higher than all of the state of Nebraska. Yeah. But one of the things that we have done this summer is we actually will partner with the libraries to offer testing to youth who can't afford testing. And if they're positive, we go back and find them and treat them. That would be a good place to actually work or implement your program?
Yeah, absolutely. And the libraries have become more open to allowing that sort of thing here in DC. They've offered HIV testing on National Testing Day, on an HIV national, December 1st, National HIV Day, World AIDS Day. So that is a way to partner. Did you guys actually train library staff to do that, or did you have staff?
No, I actually go out and I implement STD testing, not just HIV testing, but STD testing. And I just set up a time at a certain time every week. Since it was over the summer, it was twice a week. But since school started now, I do it once a week where I go from about the time I know they'll be getting out of school till like 4:30 or 5, where I know that after a while they'll get used to you being there, and then they'll start sending their friends to you. Well, you don't have to go in the library and ask people if they want to get tested. You don't have to walk around. They'll actually know you're there and come to you.
Right, exactly. And we were just talking yesterday about how to set it up even at Parks and Rec centers so that our staff doesn't actually have to be there, but we've got staff who are trained through those other agencies to be able to offer it, so it just becomes this kind of satellite site.
That would be cool, especially if they only do the cup.
Yeah, which makes it easy because you don't have to be, a rocket scientist to do it.
Right. What we also how to advertise it at the library is that we placed it. They made pretty flyers and they taped them to the bathroom walls, the stalls. Mm-hmm. And so people also knew, even if they came during any other time of the week, on Tuesday they can come back and get tested for STDs.
Yeah, great.
But I prefer your method. But
don't give up. Conservative areas, if you've got the data to back it up, you can find those parent groups that'll let you in and find that one school that is willing to go there. Parents really get concerned it's around lack of control, and by giving them the opt-out form, they have that control.
Well, and the other question I have for you is was this broadcast or this webinar, was it taped? Can we have a tape of it or?
Say that one more time.
Can we have a tape of this seminar or webinar that you just gave us of what you guys did to implement testing in schools?
I'm sorry to interrupt. Absolutely. This is Sandra from NCSD. We're recording this. We'll have it archived with the whole slide set as well, and we will be emailing that out to all the participants and anyone who's registered.
Okay.
So you will have access to this.
Thank you.
Oh, no problem. And I know we're a little over time. We'll allow for one more question. Again, I apologize for the time crunch. Anyone?
Thank you again. Does someone else have a question on the line? I think I might be the only one. I had a quick question. I was just thinking about the whole idea of this vaginal swabs coming out as a testing method. I'm just wondering if you all had considered that, or your plan is to kind of stick with the urine-based as a kind of a one-stop shop, or if you were thinking of expanding to vaginal swabs for females that wanted to be tested.
That's a great question. We have talked about it. Charlotte Gatos up in Baltimore, just quick up the road from us, has done an amazing job and just put out a lot of information and research on it. And so we've talked about it, and we haven't made any decisions about switching. I think we'd be hard-pressed to convince teenage boys to do a self-collected swab. So we need to stick with urine with our boys. But we have talked about the vaginal swab because it's been proven to be a bit more accurate and pick up even more. But we haven't done any switches because right now, kind of getting our feet and implementation under us, it's easier to stick with both. We've talked about even including the cards for young people to use her system as a 3-month follow-up. We just haven't gotten to actual implementation for that.
Okay.
Yeah.
All right. Great.
Okay, thanks everyone for being a part of this, for participating. Again, I apologize for going over. Thank you, Melissa, for a wonderful in-depth presentation about what y'all are doing here in the district. I'm very pleased to have the opportunity to be able to assist with having our project areas share their stories out out with their colleagues, so I appreciate you for taking time to present today. Final exit notes, if you will. As I mentioned before, we will have an archived recording, and the presentation slides will be sent via email. We have an evaluation. We absolutely need your feedback in terms of our ability to continue to produce webinars like the one we have now. And finally, if you happen to have participated on the webinar 2 weeks ago and have not completed that evaluation, the link is posted as well. I just want to say, in addition to blasting out the archive link via email, we will also include Melissa's information with that and a link to the evaluation. So thank you so much for your time. Have a wonderful afternoon and rest of the week. Thank you all.
Thank you. Please stand by.